I'm sorry for these technical issues with this particular slide deck. So my talk today is going to be on how can we improve the outcome of preemies. Now I remember this discussion I had with a doctor couple who came to us with a 27-week IUGR baby. The fetus estimated fetal weight was 650 grams and there was absent Doppler on absent end diastolic flow on Doppler. And I was stunned to hear from them that they were not sure about continuing care. And for me, at 27 weeks, it's not an option. And when I dwelled into what the issue was, their concern was not so much about survival. They said, whatever be it, if the baby survives or not, that is God's wish. But our major concern is long-term outcome. If the baby survives, is there a risk factor for adverse neurological outcome? Unfortunately, I had to tell them yes. We see here that in ELBWs and extremely low gestational age babies, the systematic review done from India has shown that the survival is around 34% in ELBW and 39% in extremely low gestational age babies. And particularly in low and middle income countries, this survival is very poor. But when you look at neurodevelopmental impairment, overall, across the globe, yes, these babies have a high risk of neurological impairment. Having said that, the lower the gestational age, greater is the risk for neurodevelopmental impairment. But if you ask us, can we improve outcomes? My answer is a very, very strong yes. We can do something to improve their outcomes. In fact, we can do many things to improve their outcomes. And today, over the next 30 minutes, I'll be discussing 10 simple things, of which I would say that 9 of them can be done even in a level 2 care. And a part of the 10th one, that is optimal in ICU care, can also be done there. So I'm going to be talking about 10 simple interventions, nothing really hi-fi, that have all been shown evidence-wise to improve interventions. And this I've clubbed into antenatal interventions. We require our obstetric partners, delivery room interventions, and what we as pediatricians and neonatologists do. The first and foremost, of course, is to delay preterm birth. Less than 28 weeks, every day in utero improves the outcome of survival by 1 to 3%. So delay as much as possible. In a baby who is IUGR, Doppler is something which is really going to help us. And one message I would like to give to all pediatricians is, if there is PPROM, it is not an indication to deliver the baby immediately. You need to wait. It is okay. And only if there is abruption, chorioamnionitis, fetal distress, or a cord prolapse. These are the only 4 indications where we need to deliver in PPROM. And as you see here, even at 34 weeks, the brain of the preterm baby is quite immature. So just because the baby is 34 weeks and we can ensure survival, that is not an indication to deliver the baby. And there are a lot of strategies to reduce preterm, and we need to ask our obstetric friends to use them, like progesterone for all women at risk, like, for example, a previous preterm. If the cervical length is less than 2.5 centimeter, give progesterone. Aspirin is another drug which has been shown to reduce preterm births. Cervical cerclage if the cervical length is small, and simple interventions like tobacco control. And now the huge use of assisted reproductive techniques, that has to be very judicious. We have to have a responsibility while using ART so that we don't have this huge burden of prematurity. The second most important intervention is antenatal corticosteroids. It's been more than half a century since it has been discovered, but even now the safe use of it is not very good. I was lucky to be part of the WHO team which conducted this large randomized controlled trial on antenatal dexamethasone for early preterm birth. This was published in NEJM 2 years ago, and this has shown categorically that even in the low and middle income countries, use of antenatal steroids improves outcomes by improving survival, decreasing respiratory distress syndrome, IVH, and it also improves the neurological outcome. And therefore, just last year, there has been a new recommendation by WHO on the use of steroids, that do not use it just like that for any preterm birth. There has to be 5 criteria which are satisfied. That is, you need to have a gestational age assessment accurately done by an ultrasound. Preterm birth should be imminent. It is not that this baby is a precious pregnancy and therefore you give antenatal corticosteroids at 28 weeks. It should be an imminent preterm birth. There should not be any clinical evidence of maternal infection, and give steroids only if you can take care of the women at birth and the baby after birth. At least a minimum care package of CPAP and ICU facilities should be there. Because steroids, which when it's not used safely, can actually increase newborn mortality, as it has been shown in some trials. The third simple intervention is magnesium sulfate. This is not for survival. When we use magnesium sulfate in women less than 34 weeks, if they are in preterm labor or at risk of preterm birth, the neurological outcomes are far better. We are not talking about Maxal for the mother's sake when she has preeclampsia. This is for the baby's sake, and now it is a standard of care to use Maxal for women in labor when they have imminent delivery, and this has been shown to reduce the risk of cerebral palsy by almost 32%. The third use for the obstetricians is to use antibiotics judiciously. Every preterm labor with intact membranes doesn't need antibiotics. In fact, use of antibiotics in them has been shown to increase newborn mortality. But in PPROM, when membranes have ruptured, it is very clear that use of antibiotics reduces chorioamnionitis, neonatal infection, and it improves outcomes in the babies, including neurological outcomes. So antibiotics, again, judicious use. Those 4 were the interventions for the obstetrician. Now I'm going to talk about interventions, which is our common area, that is the labor room. In the labor room, we need to request the obstetricians for just 1 minute of theirs. And what is that for? That is for delayed cord clamping. Even in the preemie, delayed cord clamping is recommended. But we did a small study to look at what about babies who need resuscitation. We are not able to do delayed cord clamping in them. This was a randomized controlled trial which we did and which is published in the prestigious Resuscitation Journal, where we saw that if in babies you can't do delayed cord clamping, cord milking 3 times of the cut cord as resuscitation is being done, improved outcomes like increased the ferritin levels and also reduced anemia. Similarly, nowadays, what has been tried is to do resuscitation along with placental transfusion, what is called as resuscitation on the intact cord. And you have some new equipment like this, which can be pushed into towards a delivery trolley, and the baby can be kept on this particular equipment, kept warm, and resuscitation can be done before the cord is clamped. Delayed cord clamping reduces mortality, and cord milking is good, but not only for babies more than 28 weeks. And the new kid on the block is resuscitation on the intact cord. What else can we do in the delivery room? This is something we all know very well. We have to keep the baby warm. Less than 32 weeks, what is recommended is a plastic wrap or bag. And now it is known, and this is the theme for this year's World Prematurity Day, that skin-to-skin contact, even for the preemies, right from birth, is recommended to not only keep them warm, but there are a host of other benefits which we'll talk about. What else is an update on the care for the preemie in the respiratory room? The resuscitation is becoming more and more complex. Now we are not only talking about a pulse oximeter, a T-piece resuscitator, an oxygen blender, but we also now, people are looking at having a respiratory function monitor. And this has been shown to be feasible in resuscitation, though we still don't have large trials to see what is the impact or the benefits of this respiratory function monitor. Now, the baby is born, we have taken care of the baby well, And now let's look at what all we can do in the NICU, our core area of work. First and foremost, it is CPAP. You all may be aware that WHO has come out with low birth weight guidelines, and this was released yesterday. And this is being celebrated today with a webinar. And one of the core set of guidelines in this is about CPAP. CPAP is the modality of choice of respiratory support for a preterm baby. It is not oxygen. It is not invasive ventilation. Being non-invasive, giving CPAP, keeping the alveoli open, that is the core principles of respiratory support for the preterm. Avoid intubation as much as you can. But if the baby really needs it, then volume ventilation, volume targeted ventilation is a choice. When we look at DR CPAP in the delivery room and continue to into the NICU, use of CPAP compared to mechanical ventilation reduces BPD. Many of the students out there may recognize these relative risk numbers, which all show that these are significant. And the one which is really important is that CPAP reduces death or BPD and need for ventilation and need for surfactant. In low and middle income countries, it has been shown that starting CPAP, giving CPAP properly has a reduction in mortality by almost 50%. Moreover, CPAP reduces surfactant use. We all know that preterm babies, many of them need surfactant. But the COIN trial, support trial, CURPAP trial, all of them have shown that if you give CPAP well, the use of surfactant may be lower. But we have now more new innovations. People are seeing that can I give surfactant without really invading into the baby? And we have this less invasive surfactant therapy where instead of intubating, you keep the baby on CPAP, just pass in a small feeding tube and give surfactant. But we are trying to be even less invasive. Don't even pass a tube. Can we give surfactant by aerosolization, like a nebulization? And that is something that even WHO has been working on. We have recently brought out the guidelines on what an aerosolized surfactant should do. And this is probably going to be the new way that we'll be delivering surfactant in the next 1 decade. The next big intervention, which all of you all know and all of us practice, but we still need to do it better, is breastfeeding and mom. What do I mean by mom? By mom, the terminology is not for the mother, but mother's own milk. And we know for the preemie, this is actually liquid gold. This is actually a lifeline because it is the best food for the baby, but it's also more than food because it has so many things in it which helps the baby fight infections, improve the outcomes. And in fact, giving breast milk to the preemie, the growth may be lesser than compared to a formula-fed baby. But the mental growth, the outcome of this baby is going to be better. The baby is going to be more intelligent, both in neuromotor as well as psychological way. And this is known as the apparent breastfeeding paradox, where growth may be lesser, but the neurological outcome is better. And preterm breast milk has really much more than even term breast milk. This slide here shows that lower the gestational age, the protein content is higher and it remains high for a much longer time. Now, it's not only about human milk, it is about mother's own milk. Even when you compare mother's own milk with donor human milk, because I know in Tamil Nadu, you have managed to get milk banks in almost every district. Even when you have a milk bank, the emphasis should be on the mother expressing for her own baby. Because as you see here, the benefits of mother's own milk for her baby is far more than donor human milk. That is why I say mom means wow. It's a wow factor. And I have 5 easy steps of doing it. First and foremost, let's remember, even when the baby is sick and we are taking care of ventilation and trying to save the life of the baby, we need to counsel the mother for early and frequent expression. Very often mother says, no one told us that we have to express milk. And only when she has breast engorgement on day 3, day 4, she starts expressing. So early frequent expression, kangaroo mother care and skin to skin contact, breast massage, and treat the mother's own milk as a medicine. Chart it, make sure you give it. And it's all about team effort and giving a support to make the mother calm so that she can express her own milk. In addition to mother's own milk, we need to have a good protocolized feeding regimen, and we should be very, very aggressive about feeding these micro preemies. We have data from India itself that we can start on full feeds for even a 1,000-gram baby without any problem. Having said that, we still need to fortify the mother's own milk because it may be deficient in certain factors like calcium. And the other big intervention is kangaroo mother care. This is, as I said, the theme of this year's World Prematurity Day. Zero separation starts soon after birth. This is again a lifesaver. As you see from the Cochrane meta-analysis, this can bring about a reduction in mortality as much as 40% and reduction in various other problems like sepsis, hypothermia, hypoglycemia by a huge factor like 65 to 88%. Not only that, the benefits extend into infancy, where readmissions are lower, breastfeeding rates are improved, and even the neurodevelopmental outcome and growth is better. This is a very elegant study done by a nurse for a PhD thesis in Calcutta, which showed that even when babies are exclusively breastfed, doing kangaroo mother care improves their neurodevelopmental outcomes by 1 year. They use Darcy to look at it, but it doesn't end at 1 year. Kangaroo mother care was started in Bogota, in Colombia, in South America. Now, those babies who were part of the randomized controlled trial 25 years ago, this group have followed them up and now they're all adults. They took this group and did a battery of tests on their brain and found that 20 years later, these babies who received kangaroo mother care, their brain was very similar to normal term infants. Their neuromotor disability was lower, their school attendance was better, and in fact, they were even earning better. So the benefits of kangaroo mother care extends all the way till adulthood and probably lifelong. We did a small study where we just compared babies who got early KMC less than 3 days and who started KMC a little later. And we also looked at whether they got prolonged KMC, which we defined as more than 8 hours. And when we compared these two groups by BSID test, we found that at 1 year, starting KMC early and giving for more than 8 hours improved their scores in almost all aspects of the BSID domains. Now, this brings me to one of the wonderful studies that I was associated with as a WHO consultant, that is the immediate kangaroo mother care study. Now, this study was a large randomized controlled trial enrolling more than 3,000 infants in 5 countries, 4 in Africa, and in India, it was in Sathya Hospital. Now, this, what it did was, they started giving kangaroo mother care even before the baby became stable. This was a huge paradigm shift because we needed to now make the NICU into a mother newborn ICU. So this was a paradigm shift. Now, here you see in Sathya Hospital, this is an NICU. You have a warmer, you have monitors, you have CPAP, but the big change you see is having an adult bed and the mother there, and all care which is given in skin-to-skin contact. This is going to be the new phase of the neonatal ICU. Now, that is going to make a huge difference in improving outcomes. And as I said, this immediate KMC trial has now brought about new guidelines which were released yesterday, that kangaroo mother care is not only for babies less than 2 kg, but even for all low birth weight. So that's one change in kangaroo mother care guideline. Give it not less than 8 hours. Before we used to say as much as possible, but now we are very clear, as much as possible, yes, but at least 8 hours duration. The third big change is that even at home, if a baby is unable to go to a hospital, you can initiate kangaroo mother care. But the big change in guideline is don't wait for stabilization. Even in the sick infant, even if a baby needs respiratory support, start KMC at birth and give continuous KMC as long as even 20 hours per day. The next 9 thing, I have clubbed everything into optimal NICU care. This is what we all do. We need to prevent hypothermia, hypoglycemia, hypoxia, hyperbilirubinemia, and you heard a lot about hospital-acquired infections. If we can prevent these dreaded H, like say the dreaded H combination, we can improve outcomes in all what I've written on the right: BPD, IVH, ROP, NEC, PVL, and of course, survival. So one of the things that we need to look at is when we use oxygen, we need to use it safely. We never should have any hyperoxia, and our oxygen targets would be 91 to 94%. A lot of work is now being done to understand oxygen delivery at the tissue level. There are a lot of trials on NIRS and also trials on looking at automated FiO2, which measures the saturation and automatically gives a feedback for the oxygen delivery unit so that it can, if there is hyperoxia, it will reduce the oxygen which is given. One big thing we need to work on is infections in these babies. And for us in St. John's, infection control has become the new mantra. We started a quality improvement program in 2015 as a DM neonatology thesis. And we have now made this big change in our thinking that preterm babies, it's not that infections are inevitable. They're totally preventable, and we need to have zero tolerance. And probably this has been my most satisfying work in life because this has shown directly its effect on newborn mortality. As you see here, our newborn mortality in the unit, once we started this QI program, reduced, and we had an NMR of as less than 4 per 1,000 live births in our unit in 2017. So what are the 10 steps for prevention of infection? For me, the first 5 are the most important, and you heard a lot about it. It was wonderful to hear about hand hygiene, bundle care, antibiotic stewardship, but also remember breastfeeding and KMC is a very important aspect of prevention of infection. In addition, we need adequate staff, adequate disposables, and focus on standard precautions, housekeeping, and disinfection. Having a good team is extremely important, and keeping our nurses happy is one of the basic fundamental things in the NICU to ensure you improve your outcomes. Then I've kept drugs to the last. It's not that drugs are the be all and end all. Yes, there are many drugs which improve outcome, particularly caffeine. That's again a new guideline which has come out that for treatment of caffeine, for treatment of apnea, or in peri-extubation, it is a strong recommendation to use caffeine. This was the landmark trial by Barbara Smith, that is the CAP trial. And this has shown that, and they've followed up these babies even into childhood and into teenage, that it makes a big difference to them. We used to be very scared of postnatal steroids, but now we know that when you use low-dose steroids and you use it in a very stringent manner and carefully, BPD is reduced. And we don't have to be very worried about neurodevelopmental outcomes. So these new trials have given us more assurance on use of postnatal steroids when needed. I must talk about probiotics because it's a very controversial area. The various studies on probiotics have all shown that it has 3 major benefits: reduction in NEC, reduction in sepsis, and improvement in mortality. Based on this strong evidence, this time, WHO has brought a new guideline. It's a conditional recommendation for less than 32 weeks. Do consider probiotics to reduce your 3 important adverse outcomes. The next thing, which is a little more controversial, is erythropoietin. The meta-analysis in 2017 had shown that it improves neurodevelopmental outcome. But the huge trial, which was published in NEJM 2 years ago, that's the peanut trial, has really not shown a benefit. So it's still not a big recommendation. My last thing is, whatever you do it with love, do it with care. Developmentally supportive care, where we look at the baby in a humane way. Make sure that the baby doesn't get pain. You protect the baby from pain. Make sure the baby can sleep well. Make sure the baby feeds well. And healing environment is there. And it's all about family-centered care. As you see in this picture, developmentally supportive care is all about putting the mother, baby together and all the time. And that's again the theme of our World Prematurity Day. Developmentally supportive care has huge positive effects even at 5 years, both in behavior as well as motor outcomes. So those who might 10 simple interventions to save the preemies, not only for their survival, but also for their better neurodevelopmental outcome. Thanks for your patient hearing and also bearing with me for the technical issues.